Before going to measure,
ಒಂದ್ಸಲ ಅದು ಫೋನ್ ತೆಗಿಯಕ್ಕಾಗುತ್ತದೆ.
ಕೇಳಿಸಿದೆ ಸರ್? ಹಲೋ ಹಲೋ ಸ್ಟಾರ್ಟ್ ಮಾಡಲಾ ಸರ್? ಹಲೋ ಕ್ಯಾನ್ ಐ ಸ್ಟಾರ್ಟ್?
ಸರ್ ಫ್ಲಕ್ಚುಯೇಷನ್ ಬರ್ತಾ ಇದೆ.
ಓಕೆ.
ಸೊ ದಟ್ಸ್ ದ ಓನ್ಲಿ ಥಿಂಗ್. ಅದು ಸ್ವಲ್ಪ ಇದು ಮಾಡ್ಕೋಬೇಕಷ್ಟೇ ಸರ್. ಇಲ್ಲಾಂದ್ರೆ ಅದು ಇದು ಹ್ಯಾಂಡ್ಸ್ ಫ್ರೀ ತೆಗೆದು ಮಾಡಕ್ಕಾಗುತ್ತಾ ಸರ್?
ಈಗ ಕೇಳಿಸ್ತಿದೆ ಕರೆಕ್ಟ್ ಆಗಿ?
ಇಯರ್ಫೋನ್ ಫ್ರಮ್ ಯುವರ್ ಲ್ಯಾಪ್ಟಾಪ್ ಡೈರೆಕ್ಟ್ ಕೇಳಿಸ್ತದೆ. So welcome everyone. Thank you very much again for all the participants in NF web series right from the beginning for 3 months. We would like to extend our warm welcome for today's session. Today we have Dr. SUNIL. Dr. SUNIL B is a professor of pediatrics and neonatology at Kempegowda Institute of Medical Science, Bangalore. Sir, welcome to NNF Karnataka chapter web series. Welcome from on behalf of the entire NNF Karnataka office bearer and members, sir. Welcome to you, sir.
Thank you.
So today's talk will be on neonatal respiratory chapter. So the first talk will be on apnea of prematurity, recent advances, followed by the second talk by Dr. KARTHIK Nagesh, is a professor and head of the department and chief neonatology for Manipal Institute of Medical Science. Welcome to you as well, sir. It's our privilege to have such a great speaker, Dr. SUNIL and Dr. KARTHIK Nagesh, sir. Over to you, Dr. SUNIL, sir. And today's session will be moderated by Dr. Sidhu Cherki. He is the assistant professor at BM Patil Medical College. Joining. Over to you, Dr. SUNIL, sir. Please start the session, sir.
Yeah.
Yes, sir. You can start the session.
Prematurity. First, we should know what is prematurity. Premature is a term from where it usually in neonates classified less than 37 weeks of gestation. It is defined as cessation of the breathing. Maybe we would have thought it is a pathological, but basically it reflects a physiological rather than pathological, mainly because of the immature state of the respiratory control. Then coming to the definition of the apnea of prematurity, it is a cessation of breathing by premature infant that lasts for more than 20 seconds, or cessation of breathing for less than 20 seconds if it is accompanied by hypoxia that usually is seen clinically by desaturation, the oxygen saturation, or bradycardia. Then what are the incidents of apnea of prematurity usually? Important thing is it's usually inversely related to the gestational age, as we know. Around 7% gestation age of 30 to 35 weeks, around 7% will be there. Around 30 to 33 weeks, it's 15%. As the gestation decreases, the incidence increases. As you know, then 30 to 31 weeks, around 50% of the neonates are there. Around less than 29 weeks or 1 gram per less than 1 gram, nearly 100% may encounter apnea of prematurity. Before going to the types of apnea, we know what are the forces which keep open the upper airway. So that we know common thing is mixed apnea, in that obstructive apnea next common. So that first thing is we can see that the ala nasal muscle dilate the nostrils, which opens the first part of the upper airway, and importantly genioglossus muscle of the tongue, which pulls the tongue so that it pharyngeal muscles will be taut, so that it will not be relaxed, so that it will not be obstructed. Same thing with the intercostal muscles, which keep open the rib cages. Rib cage will be stiffened. Diaphragm also helps in descent and the upward pull on the lower rib cage, where the caffeine also acts on the diaphragm. When it coming to the types of apnea of prematurity, there are 3 types are there. One is central, obstructive, or mixed. Mixed is the commonest variety, which present with around 50 to 75% of the cases, followed by obstructive and the central. Then the response to the respiratory muscle, so that the baby is not able to breathe because there is no signal from the medullary center. due to the brainstem control of the central respiratory drive. The premature infant also manifests as immature response to rotate. Then coming to the obstructive apnea, which usually we encounter in the NASH status, where secretions will be there. Sisters or the resident should suction the upper airway so that we can able to prevent the obstructive apnea. Yes, this is the air respiratory effort. This is the process of continued respiratory effort. This is because the signals have a respiratory effort. It is occurs due to the obstruction of the airway within the airway, particularly of the pharynx. You can see this diagram where the dilating force and the collapsing dilating force will decrease, collapsing force increases, so that there is a pharyngeal. At the level of the pharynx, there is an obstruction will be there. Therefore, as a general measure in the management, neck flexion and excessive secretions would worsen this form of apnea, so that by keeping the neck slight extension, the secretions, decreasing secretion by suctioning the upper airway, we can prevent the obstructive apnea. Mixed apnea is a combination of both both obstructive and the central cause. Then most important, we have to differentiate the periodic breathing versus apnea. Small during the NASH also, this has to be documented whether it's a periodic breathing or apnea of prematurity. Most important, periodic breathing is a regular recurrent cycles of breathing of 5 to 10 seconds duration that is interrupted by pauses of at least 3 seconds in duration. It's a benign respiratory pattern which requires no treatment. This is because automatically this is the main difference between the periodic breathing and the apnea of prematurity. And coming to the pathogenesis, what is the pathogenesis of apnea of prematurity? There are two varieties are there. One is central mechanism, where central nervous system control, we know is central apnea. Then comes the peripheral mechanisms. In central mechanism, the first and foremost is the decreased central chemosensitivity to the carbon dioxide. Carbon is a good chemosensitivity to the carbon dioxide, and also hypoxic ventilatory depression will be there. Because of the oxygen decrease in saturation, there will be ventilatory respiratory effort decrease will in next slides. Then next component is the upregulated inhibitory transmitters. We know that in a central nervous system, both inhibitory and excitatory neurotransmitters will be there. GABA and adenosine are the two neuroinhibitory transmitters. When the level increases, what happens? You not stimulate respiratory center. That is the reason we should know that caffeine acts on adenosine A1 and A2, so that it prevents the inhibitory effect of the adenosine. Then comes the peripheral mechanism. There is an altered carotid activity. We are not reduced, both decreasing and increasing activity of the carotid body helps in the, it causes the apnea of prematurity. Then comes the laryngeal GER reflex, excessive bradycardic response to hypoxia. Then other features are genetic predisposition is also one of the pathogens of AOP, and sepsis and cytokines. We know that other any sepsis or inflammatory markers can cause apnea of prematurity. This slide where it shows respiratory IMN is the inspiratory motor neuron and the expiratory motor neuron. So then pulmonary volume sensors in the carotid body, where it takes from the vagus afferents and relays on the central chemoreceptor. This brain of the premature or a term babies. See, this slide depicts where the arterial carbon dioxide, what will do in arterial EBG, will diffuse into the CSF, where it stimulates the medullary center. And we know in carotid body, in peripheral mechanism, which has a barrel receptors in the wall of the carotid, this also plays a role in the stimulation of the respiratory efforts. Then coming to the carbon dioxide chemosensitivity. We all know that carbon dioxide is the major chemical driver of the respiration. Premature infants has a decreased ventilator response to any changes in the arterial CO2 which reflects into CSF. That is the reason. This is because of the decreased sensitivity of the medullary respiratory center to the carbon dioxide in premature infants. Increase in carbon dioxide usually leads to stimulation. In premature baby, carbon dioxide apex threshold is only slightly below the basin. Means whatever to stimulate in a term baby may not be sufficient for the premature baby. That's the meaning of the. If you see this slide, you can see the black dot is a premature, which is 32 weeks. White dot is a term baby. You can see the carbon dioxide sensitivity compared to the premature, the term baby is better. Same with the as the day progresses. The 2-day baby will have a less carbon dioxide sensitivity term baby. You can this is 45 also the stimulation will be less. But here with little bit of increasing 40 also the total ventilation means minute ventilation increases in the term baby advances. Then coming to the hypoxic ventilator depression and response to hypoxia. What happened? The decreased rate. For example, there is a cessation of the breathing, which we usually hyperventilation in turn have desaturation. Vice versa, desaturation also cause apnea ventilation. Same thing with the decreased oxygen delivered to the carotid body. Automatically, the baroreceptors can't sense it has bradycardia will be there. Also, apnea can also increases the vagal tone, which in fact decreases the heart rate of the baby. I think this in NASU usually we see this the vicious cycle. And then coming to the altered carotid, the neurotransmitters, we know that there is increase in GABA and the adenosine, so that the respiratory drive from the carotid will be less from the respiratory center. Important, both hyperoxia and hypoxia will have effect on the peripheral chemosensitivity on the carotid body, which results in the apnea generation. See, we know that the fetal oxygenation will be, fetal PO2 is less. Come to neonatal transmission, increase in exposure. So this causes decreased body. This causes prolongation of apnea. Again, have, for example, this is in case causing respiratory instability in the baby. Laryngeal reflex, this has been associated with some is there with the laryngeal GR. Laryngeal stimulation exact premature infants less has to come to prove GR is directly related to the apnea of premature. Then comes the genetic part. Genetic part as by studied in 2000 American Journal of Epidemiology. The diagnosis is between the twins was found 87% of the same gender of monozygote twins as present with apnea of prematurity. Same with first degree consanguinity, the odds ratios are increased to 2.9. Therefore, in telling the consanguinity, the increase in the incidence of AOP is there. Same, it has almost doubled in the multiple single gestations. Therefore, we know that genetics also plays a role in genetic. Overall picture that any prematurity or any cause of impaired oxygenation, infection, inhibitory reflexes, CNS pathology, disorders can present in apnea of prematurity. Therefore, before naming its apnea of prematurity, we should be able to identify the etiologies and evaluate and remove the causes. Then only we can tell as an exclusion what is the clinical presentation? The most common thing is we'll try to not take history in a maternal history, which has some cause of the etiology. This assessment of apnea is very, very important. Repeated apnea has at the end will have neurodevelopmental outcomes. Therefore, very important is bedside caregivers. Who are the bedside caregivers? NICU staff nurse and the residents should identify the problem and should document so that also can be usually identified. Usually, so many NASUs may have cardiorespiratory monitor which identify the apnea of prematurity. And next commonest, usually in all these setups, will have a pulse oximeter, severity and the duration of central oxygen saturation, because it is directly related to the neurodevelopmental outcome of this baby. So this slide shows some of the causes, how to monitor and how to evaluate the causes. Commonest which is the infection. How it will present, maybe feet intolerance, lethargy, or temperature impurity. For that, we usually do complete blood counts and the blood culture and treat accordingly with an antibiotic. Impaired oxygenation will have show desaturation or tachypnea, respiratory distress. This may be because of the pneumonia. We have to do a chest X-ray examination along with an ABG to confirm PO2 is less. And other metabolic disorders like hypoglycemia, hypocalcemia, hyponatremia, hypokalemia can also present with apnea of maturity. Therefore, do relevant investigations to identify and correct problem. And some of the drugs commonly is the antenatal mothers who gives magnesium sulfate for pH. These babies may present with CNS depression at birth. Sometimes if that, because in a premature, we don't know the pharmacokinetics of the baby. If the drug level stays for a long time, we may have to present with apnea of prematurity. That's why the history of the pH, hypothermia or hyperthermia can stimulate apnea of prematurity. Then comes the intracranial pathology. Commonly is any intracranial bleed or IVH in the premature baby or neonatal seizures can have all with the apnea of prematurity. For that, ultrasound rule out any other cause of IVH or neonatal seizures. Then coming to the treatment wise, what is the goal of the therapy? The principal goals of treatment if we were to address even it is premature excluded, then during the diagnosis outcome, apnea of should be presumptive etiology. For the goals of pharmacological intervention, general measures we should able to avoid, should not taken to avoid reflexes that trigger the apnea. For example, section in the pharynx deep should be done very carefully so that vagal stimulation can occur and you will have apnea of prematurity. And positions of the extreme flexion and extension of the neck should be avoided to reduce the likelihood of, so that we should teach us avoid obstructive apnea in premature babies. Then is the non-pharmacological treatment. The non-invasive respiratory support, I think that everyone knows. The non-invasive support helps in, how it helps? It helps in stenting the collapsible airways. By doing that, it reduces the airway obstruction, therefore obstructive apnea is prevented, and improves the oxygenation, which is one of the etiology for impaired saturation can also have apnea of prematurity. And reduction in, this in turn results in reduction in apneic effects and extubation rates. We have a lot of studies are there that even if extubation you put on any non-invasive method, success of extubation is high. What are the methods usually we'll follow? Till now we know that one is CPAP, that is continuous positive pressure, and high frequency nasal cannula. These are the two commonly practical in NIPP. But recently, novel method is the flow synchronized NIPP. I don't know how many units will have a NIPP, but the studies have shown that it is more effective than the conventional NIPP or CPAP to infants with AOL, apnea of prematurity. between AOP, how it helps is it helps to maintain the airway patency and avoids overflexion and extension of the neck, thus preventing obstructive apnea. The most important point, this has to be practiced in NSU with sisters monitoring the baby, because sits are very common. That's the reason with monitoring the baby only you should have prone position. Then as we know that one of the cause was temperature instability. Stable temperature and avoidance of overheating also has helped in reducing the incidence of apnea of prematurity, because has shown blend the non. Next is premature infants with apnea of prematurity and without continuous hypoxemia is also benefited with low flow supplement oxygen. For example, in level 2 care, before shifting level 3, they give some supplemental oxygen, but some low oxygen with not without continuous hypoxemia, means intermittent hypoxemia, has stabilized the breathing and reduced the apnea and periodic breathing in premature babies. And most importantly, maintaining the SpO2 range around 84, the incidence of why it is 88 to 94, because of the hyperoxia can also have benefits on effect on the eye for retinopathy of prematurity or periventricular leukomalacia. To prevent that, they have targeted SpO2. They have done a meta-analysis that just showed that there is a apnea of prematurity by maintaining the SpO2 of 88 to 94. And a lot of methods they have told. For example, physical stimulation also first step, the respiratory efforts will be there. Then come olfactory stimulation. These are the studies I have gone through it. But commonly we may do physical stimulation, sound stimulation using material sounds. Have found that reduce the incidence of apnea of prematurity. And one more interesting is the increased low respiratory carbon dioxide, so that the CO2 range in this. Then comes everyone knows if anemia is there less than 7, if apnea is there, we give blood transfusion. Some studies have also shown that red blood cell transfusions when there is an anemia has helped to decrease the. These are not clear evidences, but a lot of studies have shown that some beneficial effects are there for apnea of prematurity by doing all these non-pharmacological methods. Then at the end we'll come to the pharmacological intervention. Commonly used are methyl the two in that caffeine. How these will work? This will stimulate the medullary respiratory center through antagonism, means with inhibiting the adenosine 1 adenosine receptors, which we know that these two are the inhibitory neurotransmitters. By blocking this, automatically it will increase from the respiratory center to the respiratory inspiratory muscles. And also it's in increasing the carbon dioxide sensing, where we know that there is a premature baby, carbon dioxide chemosensitivity decreases, so that it helps in increasing the carbon dioxide in the oxygen sensing. Also improves the diaphragmatic function, so that diaphragmatic helps in keeping open the rib cage. And also on the bronchioles, it helps in bronchodilation. As a net effect, it increases in the minute ventilation. Therefore, by reducing the the one which is used. Why it is used? This is mainly because of the wider therapeutic window, the better safety profile as compared to the methyl agents. Because of the wider therapeutic window, a lot of units will not therapeutic range of the caffeine. Usually we require to do in aminophylline or a theophylline. What is the dosage usually give? Loading dose of 20 mg per kg of chemicitrin, IV or orally. If you give IV slow, give you over 30 minutes. The maintenance dose commonly practiced is, and the NAGESH is 5 mg per kg. If, for example, the episodes of apnea is not decreased, we can increase to 10 mg per kg, beginning with 24 hours after the loading dose. Then what is the therapeutic level they have told is? It is 5 to 20 microgram per ml is the one. When usually we do therapeutic level, the but the to see if is normal, then we'll go to next and what to be done. The most important, I think, when to start. So this is still it's still unclear, but recently when I got the largest trial for the apnea of prematurity with the caffeine. Earlier, what used to, after onset of, used to give the caffeine. But now the results have, I didn't get the results. But CAP trial, what they have told is early within 3 days. If you start before, means prophylactically, the baby doesn't have apnea. What are the advantages they found out? There's a shorter duration of mechanical ventilation. There's a decrease in incidence of bronchopulmonary dysplasia, and also neurodevelopment at 18 months and 11 years. There is some improvement they have seen. Probably that is the majority of the units have started. Then next comes the cessation. Timing is so difficult. Still, there is no standard protocol, and when to baby stopping the couple. We have identified there is a substantial intermediate hypoxia after 34 weeks of gestation, which has effect on the neurodevelopment outcome of the babies. Some studies have shown, 2017, they found out that because of intermediate hypoxia, neurodevelopmental outcome problem will be there. That's the reason they have used extending the caffeine treatment up to 40 weeks. These may have intermittent hypoxia during the NICU stay. Therefore, majority of them will try to give up to 40 weeks because it is helping outcome, and also safety profile is has been. Then we should, if you read apnea of, it's the largest trial caffeine synthesis, where caffeine and the placebo is given for first 10 postal days to prevent or treat apnea or to facilitate extubation. What I will do is I will give you the immediate outcome and outcome. Will not go in detail about the what they did a study. Okay. What happens immediately that they what they have found out is reduction of the bronchial dysplasia. Most is improved survival without neurodevelopmental disability at 18 to 21 months. This has been proved because it's the longest study what we have got in the CAP trial. Then is the neurodevelopment outcome they have studied at 5 years and 11 years. But at the at 5 years there was no much difference. Difference in the neuro radiomotor, visuoperceptual abilities at 11 years of age. And also, most important, the safety profile was good in the caffeine citrate. This is the outcome what they have done caffeine CAP trial. In any drug, we know there will be side effects. For example, commonly, or is untrained, we should be able to unbiased mind. We should also have whether drug has caused anything. We should check the drug, how much dosage they have given. Feed intolerance is known. Increased metabolic rate, insulin consumption have been reported. One with standard dose of caffeine. This has been studied in 2008 in a. Then next molecule is usually we use a doxapram. What is doxapram? It's a respiratory neurostimulant that increases the how it acts. What is the difference between the caffeine and doxapram? It directly acts on the central chemoreceptor or through sensitization of the peripheral chemoreceptors to the hypoxemia as of methylxanthine. But it is mainly used, very important, is second line therapy after the caffeine failure. For example, you are given caffeine, we have ruled out other causes, but still you are feeling it's apnea of prematurity. Then we may have to consider adding doxapram. How clinically what you start? you have to start 0.5 milligram per kg per hour. That could be increased every 12 hours up to 2 milligram per kg per hour. This also what they have to, when high dose only, there are some side effects like cardiac conduction disorder, gas, high dose of gone. A lot of retrospective studies were there which are supporting doxaprime will be useful when there is caffeine failure. But I got only one prospective study done which had 106 very low birth weight babies, where what they have done is they have taken only one group as a caffeine group, one with the caffeine with doxaprime. What they have found is 80% of the success rate in reducing the apnea frequency, significantly reduced death rates in doxaprime treated infants along with apnea. Doxaprime is beneficial in infants with persistent apnea despite caffeine and optimal care. But the only thing is the randomized control, late outcomes of premature infancy in a clinical scenario, we are not able, we are not usually will not come across using doxaprime therapy. Only if the caffeine therapy is failed, other etiologies are ruled out, still we see apnea of premature, then you may have to use along with caffeine. And last one is the recent compound which is found is ampicillin. It is still is not a human trials. It increases the respiratory drive and reduces both under normoxia and hypoxia in the parental rate model. But it has a promising result in the perinatal. Still, there is no clinical trial data tested in the drug to prevent the apnea in human infants. Then at the end, after, for example, the parents will ask at the discharge whether how our baby will do well. So for documentation of apnea of prematurity, how many times the baby had an hypoxia or a bradycardia is very important to explain the parents. For example, there's a huge Canadian oxygen trial network, which is a multi-central trial, has shown that if there's an intermittent hypoxia, that is SPO2 less than 80%, bradycardia less than 80, for 10 seconds or longer in a premature infants, there are some effects on these premature baby as the age progresses. For example, in this study, the primary outcome, what they found was the increased risk of late death or disability by 18 months of cardiac age. Therefore, using apnea for more prolonged, it has helped in neurodevelopment and also survival. Cognitive with hypoxic event than bradycardia. Most important, what they have found is than the bradycardia, hypoxic event less than 8% outcome in this.
Thank you very much, sir. Thank you for the wonderful presentation. We will take up all the questions and all the doubts will be cleared. I'm sure there are a lot of questions which are popping up already. Sir, we'll move to the next topic. I request Dr. Karthik sir to start sharing the slides, and then once the session is done, then we'll go for discussion. Thank you very much, sir. Sunil sir, it was wonderful presentation. I'm already getting very good feedback. Thank you, sir. Thank you, sir. Thank you. Karthik sir. Dinekar sir. Sir, you can start the presentation. Karthik sir.
Prashant,
Yes, sir. Yes, sir.
Okay,
Yes, sir.
all the audience. We have started from today respiratory chapter till next Sunday, not this coming Sunday, till 14th. We are going to do complete respiratory chapter. Complete neonatal respiratory chapter, including high frequency ventilator, invasive, non-invasive, and conventional ventilator, humidification, then all the things about the respiration. So we have included even other state speakers like Kerala, Nadu, Andhra Pradesh, Telangana, and Karnataka. Karnataka, we have already included from all the districts speakers. They have done some work in the respiratory chapter, neonatal respiratory chapter. So till Karthik comes, just I think so. Next will be what is it? Meconium aspiration. Is it right? Anita Nayam Gaudar.
Yes, sir. Yes, sir.
Next
Yes,
talk will be Anita Nayam Gaudar. That next talk will be Ajay S.A. Egg leaks. Like that, it will keep on going on. All the rest, conventional ventilator, humidification, HFO, then the non-invasive ventilation, CPAP is different. Today, Sunil was talking about CPAP. Then what is that NIPV? NIPPV and synchronized NIPPV. Then what is DOPAP? What is CPAP? What is single limb CPAP? What is double limb CPAP? What is non-invasive ventilator? What is the non-invasive HFOV? So all those things. Karthik has come.
Yeah, I have come. Can I share my slides now?
yeah. Please start sharing
Please,
slides.
sir. We are waiting
Yes,
for you.
yes. Thank you so much, Prashant and Dr. Dinkar and Dr. Kutresh for having invited me for this wonderful seminars which you are organizing. On behalf of NNF Karnataka, we thank you again. You people, you and Dr. Dinkar have probably completely changed the scenario of academics in the country for the last 4 years. I know you have done so much work in academics. It's really such a pleasure to be talking in this August forum. And you have set the standards very high for neonatal webinars also. So without much ado, I'm going to talk, and I also want to just share the fact that it's such a for Karnataka, my heart. I've been earlier past president of NNF Karnataka, and really the legacy is being carried on by the wonderful work you people are doing. Now, I'm going to talk on respiratory distress in preterms and term baby. It's a very basic algorithmic approach which I want to share with you. Forgive me if I talk something which people don't know much about, but I think the next, as Dr. Dinkar said, the next set of webinars is going to be on respiratory care. And I think this sets the pace for trying to see how to start from the basics and then go on. I have been a pure clinical neonatologist for the last about 30 years in the city of Bangalore. And the last 40 years, I've been associated with neonatology in this country, starting from my earlier postgraduate studies. I can vouch for it that neonatology today has reached almost the pinnacles of what in the 30s, starting with the early 80s when we are including the small new this country, mostly clinical research and excellent training programs have started last 25 years or so. Now, if you look at in terms of neonatal care services, most of us have been looking after babies with respiratory problems. If you look at even neonatology per se, the babies who become sick, nearly 50% of the times they are sick because of a respiratory problem. There has been a lot of improvement in terms of technology, protocol, systematization, infection control, neurodiagnostic, adjuncts to therapy. But I would still say respiratory system and its care has been probably the most progressive in this last about 40 years, and for that matter, 60 years since neonatology ever took place in the world. Now, I've just tried to portray diagrammatically what has happened for the youngsters who are young fellows in training in neonatology and pediatric trainees. It all started in the late 50s when surfactant was discovered by Professor Mary Allen Avery. Subsequently, mechanical ventilation was probably the best thing we could have happened in the late 60s. The other thing which made a big improvement in neonatal and infant mortality survivals was surfactant therapy, which some of us had the privilege of starting even in the early 90s, along with almost parallelly the rest of the world. Antenatal steroids has made a big dent in the respiratory problems of preterm babies. Mandatory ventilation and subsequently the last decade, the 2000s, saw a lot of changes in the face of neonatology, a lot of adaptations in technology, trying to better do for the babies. Amongst them, I think the wonderful thing was volume-triggered ventilation, volume-targeted ventilation. In addition to that, CPAP in the end of the 2000s became almost synonymous for premature babies to be given at the time of birth after a lot of trials like the COIN trial and the other trials like support were published. High flow nasal cannula, this last decade, we have seen it increasingly being used, particularly so for babies who are after ventilation or after CPAP, you need to do them. It's probably not as good for the primary mode in babies who are less than 28 weeks of gestation. We have been still giving surfactant, but then we are giving it to more without intubate the babies most of the times. There was a time when we thought at the time of birth, babies need to be given good respiratory care, lungs need to be opened up, the fluid needs to be drained out, and sustained inflation therefore was kind of a fad for some time, but it has been proven beyond doubt that it doesn't work and more harmful to the babies. We're looking forward to giving surfactant even non-invasively using generalized surfactant. A lot of studies are going to come up in the annual, and stem cells in BPD is probably the next new thing we're all looking forward to. So you can see how much of neonatology has changed in respiratory care. But what is very clear, there has been a great paradigm of change. Luckily for some of us, the oldies, aggressive forms of India in respiratory technology we used to do for babies. But the last about 15 years or so, we have started realizing that we have to be very gentle with the care of these babies, especially mature, because of the fact that we now know that volutrauma and atelectotrauma can occur and cause more damage to these babies. So like the extraterrestrial, the endotracheal tube is out of the NICU most of the times. The scenario of NICUs in the country, like our NICU, we have 16 ventilators all the time not working. Whereas at one time, 10 years back, they were ventilating all the time. They are just standby now. Hardly we use it. Occasionally we use it for diaphragmatic hernias, pulmonary hypertension, respiratory failure if the baby has prolonged apnea and severe RDS also. Exit procedures, if we have to ventilate babies, or for hypoxic encephalopathy, we do need to ventilate babies, or for metabolic disorders. Otherwise, we are hardly intubating and ventilating babies. Now, coming to how to start about looking after a baby who has the potential to become respiratory distressed, and therefore it all starts even prenatally. We've got excellent guidelines. The ILCOR, NRP guidelines are available for term babies, preterm babies, what to do at the time the baby is delivered, what to do till the baby is stabilized. And you have good oxygen targets which are now available for preterms also. Dawson's chartable now, which say that try to target saturation reaching of at least 80 to 85% by 5 minutes of age when you're trying to resuscitate a preterm baby. Otherwise, the prognosis, both immediate and long-term, is not good. You have target saturations available for term babies all the time available. So our job as a neonatologist starts in the delivery room. We're trying to stabilize these babies or probably give some resuscitation to them. And the word I'm going to use here is now called early respiratory care. After this, what happens? Now, most of these babies will do well if they don't have any respiratory problem. But if you now see any baby with respiratory problems starting at birth, you have a situation where it could be in the airway. You have at least 15 conditions which can cause obstruction in the airway. You can have nasal obstructions, coronal atresia the babies can be born with. Lots of times they have micrognathia. But the commonest is still laryngomalacia, which causes respiratory problems at birth. You have pulmonary complications, the 4 cardinal symptoms the diseases which cause respiratory problems are RDS, transient tachypnea of the newborn, meconium, and pneumonia. But you can be still surprised with pneumothorax at the time of birth or primary pulmonary hypertension at birth, so you have to be aware of them. I'm just listing out the causes. You have congenital heart disease, which can present at birth with respiratory problems. You can have thoracic problems like a diaphragmatic hernia, pressing on the lungs, and the pulmonary hypoplasia associated with it can cause. You can have babies born with encephalopathy, hypoxic, and they have neuromuscular difficulty in breathing well, and therefore they don't breathe well and they get into respiratory problems. So the other things which are non-respiratory also we have to look at it. There may be non-pulmonary, non-cardiovascular, and there could be other diseases. For example, sepsis with its attendant metabolic acidosis can cause respiratory distress in the baby. Hypothermia itself can cause respiratory distress and inborn errors of metabolism as well. So you have a host list of problems which can be the reason for causing respiratory distress. But I would like you to probably think as we think most of the times, either the oxygen is reaching the lung or it is not reaching the lungs. If it's not reaching the lungs, probably there is some obstructive airway, probably an upper airway or something, some obstruction. There could be also a central hyperventilation. The child could be not breathing well and therefore the oxygen is not reaching enough into the lungs for oxygenation to occur. On the other hand, the oxygen may be deprived in the baby because of severe pulmonary hypertension, because of right to left shunting in the lungs or extra pulmonary, or there could be a congenital cyanotic heart disease. Or if the child is getting enough oxygen, but the child is still not taking, is looking cyanosed and is breathless, probably there is a ventilation perfusion mismatch inside the lung. There's a lot of intraductal, intrapulmonary shunting occurring. The commonest reasons are hyaline membrane disease and even meconium aspiration in our circumstances. So if you look at this basic broad guidelines, especially if the younger fellows are able to think on these lines, you'll probably be not missing out most of the common causes of respiratory problems. Now, the common four things which we are interested in which we'll be talking more in detail today, is transient tachypnea of the newborn. You have a good perinatal history. Most of us are neonatologists here. We know what are the trigger factors for transient tachypnea of the newborn. We know what are the situations which can predispose to neonatal pneumonia. Taking a good history is important. The mother with a fever or PROM. Respiratory distress, obviously more so in preterm babies, not steroided mother. It's a male infant who's more likely to get RDS. Meconium, of course, we'll always look at the history and thereby we'll be able to ascertain. So a good perinatal history can solve the problems most of the times. Now, look at this baby who's born. You have stabilized the baby, but then you need to closely observe this baby. This baby, you cannot leave this baby alone. You can see this baby having breathing difficulty. This baby needs a lot of armamentarium around the baby for monitoring the next few hours. He needs a blender, which is delivering oxygen and air blended into the mask. The mask is being given to deliver CPAP or maybe positive pressure ventilation to this baby. You can see that the baby is grunting, has got intercostal, subcostal retractions. And this baby, you really can't leave the baby alone. Probably you need to have somebody closely observing. Otherwise, the chances of this baby getting worse may worsen. Of course, you know the history. You know it has been probably a preterm baby, so this baby may be having RDS, or it could be a late preterm baby. Probably it could be transient tachypnea of the newborn. It may settle down. So close observation for the next few hours is important. So when you think of that, you would have to monitor this baby. Either you're leaving this baby in the care of a nurse who's an excellent person to be closely observing. You have the standard things which are available. Long back, about in 1950s, Dr. Silverman had given this score based on the respiratory efforts of the baby, the upper respiratory and the lower chest movements, the alar nasal flaring. And you can easily give such a scoring chart given to a nurse or a resident doctor to monitor. Or you have the down score, which is probably more validated, but it can be used for term and preterm babies. But Silverman score is mostly useful for preterm babies. So you would not leave this baby unattended. You will probably monitoring the baby and keep asking the nurses whether this baby's score is lesser than before or worse than before. So you have a situation. If you were to be able to assess these babies every 1 to 2 hourly, either the child is closely improving and over a period of time, this child gets better, maybe in 6 hours, 7 hours or whatever, the baby gets better, probably to retrospectively think back that was just a transient tachypnea of the newborn because of excessive fluids in the lung, and this baby can be then shifted to the mother and closely monitored during feeding, but the child does not need a nursery care. There has been no change, and on the contrary, the child is getting a little worse. This child needs to be transferred to a nursery, need to be worked up. It could be a pneumonia, because especially in the setting of a perinatal risk score for sepsis, you need to look. Now look at this situation. If you have early term babies, more and more of us are encountering situations where babies are delivered early, sometimes because of whatever impending obstetric or fetal comps, but they cross, let's say, 37 weeks, or they are late preterm babies, let's say between 34 to 37 weeks. But those babies, we can't just let them go. About 8%, 5 to 8% of these early term babies also could get respiratory distress syndrome due to hyaline membrane disease. And our own data has suggested in about 507 weeks, you see, we found about 25% of them required NICU care with respiratory support. So if it is an early term baby and the baby has been in distress, please be kindly aware. To my young fellows, this is an important message I'm giving. You can't let this baby go unobserved till you're very sure this baby doesn't have respiratory distress anymore. The other good tool in our hands is a good X-ray. If it's available, portable, fantastic. If you see an X-ray like this, white out lungs of the hyaline membrane disease, this baby definitely, you know, in the next few hours is going to worsen, and this baby needs nursery care. Sometimes it may be a mild hyaline membrane disease like this baby with just a little ground glass appearance and a little bit of air for this baby to get into the nursery for closer observation and care for the next couple of days. Transient tachypnea of the baby usually settles down. You can see this here. There is excessive fluid in the lung. See the interlobar fissures here with fluid. Lung expanded compared to this lung. See, it's a whiteout. It's a little expanded. You can think that probably this is a transient tachypnea of the newborn, and probably it settle down. You can give some positive assurance to the mother or father that you can keep the baby for some more time observed in the labor room or the transitional nursery rather than shifting into the NICU. Pneumonias, if you see a pneumonia expression like this, also worrying. We need to shift this behavior. The armamentarium we have with us is the gold standard, which is blood gases. Ideally, any baby who needs longer time monitoring and needs to be kept in the nursery needs an indwelling arterial line if preferable, and try to monitor the blood gases. This is a very elegant cartoon Professor Satya Lakshmi Narasimha from California has made, which I think it's a wonderful thing. It tells you all about the inhaled gases, the exhaled gases, and what goes on in the alveolus inside the lung, and what goes on in the pulmonary capillary bed. You know that in babies who are sick, especially with hyaline membrane or meconium or pulmonary hypertension, there's a lot of right to left shunting. So he has suggested through this cartoon that the best thing, and we all know about it, that the best thing to do an arterial blood gas would be from the preductal site here, where you get, probably it's the right radial artery, which is the best to true intermittent blood gases whenever we need to an indwelling catheter. You would also need to probably put a pulse oximeter on the right side to get a good preductal saturation all the time. You can probably use, nowadays we don't use it much in this country because it's not easily available, but you can have transcutaneous PO2 monitoring and transcutaneous PSO2 monitors which are available. Costly though, but they can be kept in the periphery and they have a fairly good reliability and almost very akin to the carbon dioxide and the oxygen. They basically have a heated electrode through which you can get continuous monitoring. The only problem is the electrode tends to burn the skin and you need to keep changing the electrodes, and very expensive to change those electrodes as well. What many of us in the NICUs are also using is capillary blood gases. Capillary arterialized properly from the periphery like a heel prick, properly taken with a lancet in an anaerobic environment without oxygen contamination is a very good reliable thing for the pH and PaCO2, PeCO2. You can even have a mixed venous blood gas analysis, which can be done if you're having a fairly stable baby. If the child is not hypoventilating and the child is relatively stable hemodynamically, many times you may get some decent oppression of the pH and the PeCO2 from there. A bit higher than arterial pH, about 5 to 6 millimeters of mercury. So you have this armamentarium available for you to start monitoring, but the best I think would bat for is the pulse oximetry. Everybody has it available. Newer pulse oximeters are now available. They are able to extract signals which are sort of good signals from the artery. The bad signals from the venous pulsations sometimes are filtered off in the good monitors which are available with the CT technology, as we call it, or the signal extraction technology. So this is a very good thing available for us. Now, based on the pulse oximetry, we can also calculate what is called the oxygen saturation index. It has been tried out in very sick children with hypoxic respiratory failure. Dr. Lakshmi Narasimha's group from Buffalo, when he was there at Buffalo, they published a lot of this work, and they've suggested that the oxygen saturation index, which is very linearly sort of correlating with the oxygenation index, which is the one which you use by taking blood samples of the arterial blood gases, is almost a linear correlation in the sense, if you have an OSI, it's usually 2 times the OI. So it has a good correlation between OIs of about 5 to 15 or so. We also started getting interested in it because it's a very good low-cost technology which can be adapted to the periphery in smaller centers you can use. And we did a small study which we had the occasion to present at the last year's American Societies meeting at Pediatric American Societies. So we also found that it has a decent correlation, and we started using it in our nursery also. As I said earlier, the gold standard is blood gas and arterial. Difficult to put arterial lines, but that's the best thing to do. You have to maintain umbilical arterial lines as best as possible. Peripheral arterial lines in bigger children who are more than maybe 2.5 kilo are okay, but smaller babies is, but then remember that the umbilical arterial line you'll put is a post-ductal line. But then samples from there, you'll have to analyze. Lots of algorithms are available. It depends on a lot of experience, your clinical acumen, the child's condition, and then you decide whether the child is acidotic or alkalotic, what is the carbon dioxide, what is the bicarb, whether it's a mixed picture or it's a simple respiratory picture. But for the young students here, I have this thing to show. It's a wonderful algorithm, nomogram, published by, it's called the Sigurd-Andersen nomogram. If you have, for example, a pH of 7.4, which is normal, that's fine. But on the other hand, if the pH drops to 7.3 and you find, you can plot the bicarbonate here, the pH here, and you can see the carbon dioxide. So if you were to plot the pH, the carbon dioxide, and the bicarbonate, you can easily make out whether this child has got an acute pulmonary, acute respiratory acidosis, or there is some compensation and the child has got some chronic respiratory acidosis, metabolic alkalosis. So it's very easy. I think every nursery and trainee doctors should always have this in their hands or in their mobiles to determine what is the blood gas and what is the interpretation. Depending on the clinical child's condition, you can probably decide what next to do. I have my friend here, Dr. Satish Dev Pujari from Nagpur. He's a wonderful man. He's developed this arterial blood gas mobile app, which many of my own residents are carrying with them. And this can tell you exactly what is there in this picture. You feed in the pH, the bicarbonate, and the PCO2, and you get the picture. It will say compensated respiratory acidosis, let's say, and then you can decide what to do. We've been trying to do arterialized capillary samples using the iStat machine, which probably is also a good alternate, provided, as I said, the child is quite stable and not hyperventilating. Probably it may be a good option, but then we have to see the data emerge on that. The lung ultrasound is fantastic, and more and more of us are starting to learn to use more of this. And in this own forum of webinars of NNFK, a lot of topics on lung ultrasound are there. You have a normal looking lung there with A lines, horizontal. B lines suggest there's a lot of fluid and probably respiratory distress syndrome in the baby. You can easily recognize at the bedside pneumothorax. You can see the typical barcode sign. So it's a fairly easy technology to use. And I think everybody, all neonatal doctors and fellows should start practicing this very often as a screen. There's no doubt that bedside functional echo is probably one very other important tool to assess these babies, even if they have a respiratory problem. Cardiac contractility is what I look for. I am not very adept at this technology, but over the last about 7-8 years, I've started recognizing what is, by at least an eyeballing effect, what is good cardiac contractility. I can determine what could be the IVC, whether it's distensible, whether it's collapsible, whether my fluids can be decided and the inotropes can be decided based on that. I'm able to assess pulmonary pressures even at this age. Whatever little technology I know, we are able to. So I think it's a fantastic technology. More and more young students should start doing this. at the bedside, even if the baby is in the transitional nursery, apart from the fact that it's very useful for preterms to determine whether there's a significant PDA. The other thing which I've been very fond of using in the nursery is a code light source. Nowadays, even with your mobiles, which are LED lights, which are available, or maybe some LED lights which you have in your keyring, you can look for pneumothorax and pneumomediastinums easily, so that, or even sometimes severe respiratory disorders present at the time of birth. This is a very good important tool for you to have when assessing babies with respiratory distress. The NNF at this year, December, brought out beautiful guidelines on the treatment for RDS, non-invasive respiratory support for preterms, as we all have now understood. I think this is the most important. And using a grade system, the reviewers and the authors have brought about this. And this is going to be one of the parameters by which we are going to look after babies in the future. The other is European guidelines, which have been republished and redefined last year. Now, I'll just delve on a little bit of the important recommendations of this group. Basically, it is important to keep the ambient temperature around preterm babies 26 degrees centigrade. When you're resuscitating, you should use a polythene bag to keep them warm. Delivery room CPAP is important. Any baby who needs to be stabilized, who's a preterm, especially less than 28 weeks, you should use a CPAP with a T-piece resuscitator till the baby settles down. Heated, humidified nasal cannula is not very good as a primary mode in the delivery room. It's inferior to CPAP, but it can be used later when the baby is extubated or removed from CPAP. As I mentioned earlier, sustained inflation is out of the door now. You can give gentle positive pressure ventilation at the time of birth. If the baby continues to remain apneic or bradycardic, it should be heated and humidified. Umbilical cord is best delayed if it is possible. If the baby is stable, you can tell your obstetric colleagues. And the FiO2, when you start resuscitating preterm babies, you should be starting at 30% and you can down regulate it to 21%. Try not to start 100% at all. And early surfactant should be reserved if the baby is showing features of RDS after giving delivery room CPAP, stabilize the baby. Many of them may not require surfactant, but the baby starts showing signs that you should give surfactant. Now, as far as respiratory support is concerned, again, the guidelines suggest that the target oxygen saturation after the baby is stabilized, after the first few minutes, the baby's saturation target should be 90 to 94% pre-ductal. Also, non-invasive support, CPAP, is recommended as a first optimal support. You can start with pressures of 5 and even go up to 8 or 9. You have to think of mechanical ventilation strategies using only volume targeted ventilation. Most of the times, the pressure limited ventilations are now out of the door. In the United States, for example, those ventilators are not available in the NICU anymore. High frequency oscillatory ventilation is a good alternative strategy, but that's not a primary mode. It's just a rescue modality after conventional ventilation has failed. The other thing about surfactant is the technique. Really now there's no choice. People say that LISA is superior, even better than the INSURE technique. And it should be given to the baby as soon as possible, even within the first hour. If the baby has an FiO2 requirement on CPAP of more than 30%, it should be given. And the redose of surfactant may be required depending on the FiO2 requirements. If the baby requires more than 30 to 40% oxygen with ongoing RDS, the baby needs to be given surfactant again. Surfactant preparations, animal-derived surfactants are better. Coractant surfactant at the rates of 20 mg per kilo probably has got a distinct more advantage than 100 mg per kilo of the bovine surfactant. And surfactant now given with budesonide has definitely been shown to prevent chronic lung disease. And this is something we are looking forward to. The baby at the end of the first week is showing signs of early BPD, probably surfactant intrathecally given with budesonide mixture should probably reduce the severity of BPD. A lot of trials are getting published on this. Now, I have derived a small algorithm, which I'm going to share with all of you. And probably we can have discussions on this if all of us agree. This is a baby, for example, who's a 28-weeker or maybe up to 33-weeker. The baby delivers. You have stabilized the baby in the resuscitation area. The baby is spontaneously breathing. If the answer is yes, Is the baby having increased oxygen requirements or work of breathing? If you feel yes, this baby needs to be started on CPAP. As soon as possible in the delivery room itself, you can start CPAP. Keep monitoring through an oxygen and blender whether the FiO2 is going to increase more than 30%. If that is the case, the baby needs to be shifted to the NICU on the CPAP even during the transport inside the hospital. And if the baby is requiring more than 30% oxygen, the child needs surfactant by the LISA method as far as possible, preferable. If the baby's FiO2 requirements don't increase, but the baby is less, but still the baby requires respiratory support with CPAP, keep the baby monitored in the NICU. Suppose this baby is not spontaneously breathing, bradycardic, apneic, initial resuscitation steps you are done as per NRP, the child needs intubation because it's apneic. This child needs to be given surfactant. You can do it in the delivery room or you can bring the baby back to the nursery. Especially if the FiO2 is more than 30% and there's ongoing ventilation need, the baby can be given a redosing of surfactant also later. So this would be the standard protocol I would suggest for a baby who is 28 to 33 weeks. Now, the baby who's extremely preterm, who's less than 28 weeks, is a different ball game. You need to be prepared and you should need to be informed before the baby delivers. Maybe the obstetric perinatal unit should tell you, you should be prepared. Your NICU doctors may be called for counseling these parents. What is going to be the prognosis? What is the immediate outcome? You'll have to be aware to do that. The doctors will have to inquire the status of antenatal steroids because definitely 50% chances of RDS, intracranial hemorrhages, NEC, BPD, everything comes down if antenatal steroids have been given. If you were able to counsel them that they can probably give some tocolytics to prolong the delivery, that may be even better. Magnesium sulfate ideally should be given to babies less than 32 weeks of gestation also to protect the brain of these preterm babies. The obstetrician can be told. If there's a history of fever or leaking in the mother, this should be made note of because chorioamnionitis is a very high risk factor for these babies for chronic lung disease, even if they have respiratory distress and subsequent to that, and the babies can become sick. Antepartum hemorrhage, sudden delivery is a higher risk for RDS and other complications, so you need to inquire that. So the team which has to decide how to plan the delivery should allocate their roles, and all of us should do a performance equipment check. We should probably preheat the warmer or the incubator where the baby is going to be transported, arrange for polythene plastic bags and wraps, set the room temperature in the mother's room to 26 degrees centigrade. That's very important for us. And then the transport incubator has to be kept ready. Ideally, the obstetrician should be requested to gently handle the baby, avoid deep suctioning of the mouth or nose when she's pulling out the baby. And she can delay clamping the cord for at least 30 seconds to 60 seconds, especially if the preterm comes out vigorous and you don't need to be in a rush to actively resuscitate the baby. The ideal thing to do would be to keep a resuscitator, a T-piece resuscitator available with you. Do not use an ambu bag as far as possible unless it's absolutely not possible. But then again, across the world now, people have given up ambu bags or self-inflating bags. They are very injurious to the lung. The device which is available here should have facilities to give a set PIP and a PIP both. You can set it, for example, it's an extreme preterm, you can set it to default of 16/5 centimeters of water, and you should use an oxygen and air blender. Keep the FiO2 maybe 30% when you're going to deliver this baby, and make sure you have your oxygen saturation probe ready to connect to the baby's right hand as soon as the baby is delivered, so that if the baby is saturating well and the baby doesn't have much respiratory distress, you can probably give a little bit of CPAP like this baby here, along with the blender oxygen and monitor the saturations, and you're done. But you need to intubate this baby if the baby is, or maybe if the baby is having good respiratory effort, you can, the gasping breathing is there, heart rates are a little less, you can probably initiate some positive pressure ventilation through the same T-piece device. You can probably give positive pressure ventilation. Don't really need to intubate unless the child is really having a prolonged apnea with severe bradycardia. So the oxygen therefore needs to be titrated to meet the preductal saturations of about 90 to 94 after the child has become 5 minutes of age. So this would be the attempt we'll do when the baby is just then delivered. Once you stabilize the baby, keep the TP's resuscitator 5 to 6 centimeters of water. You can transport the baby to the NICU in a preheated incubator. Whether it's the NICU inside a hospital or outside the hospital, you need to transport with nasal CPAP. Now, this is a big challenge which we have been having, what catheter to use when we are giving CPAP. We found that one adaptation of a Ram's cannula can be connected to the baby with a blender oxygen. And this is good enough for a short transport. And we've been using this, transporting the baby to our NICU. Once the baby comes to the NICU, we connect the baby to a ventilator CPAP or a bubble standalone CPAP or any CPAP device you have. And the interface can be a mask or binasal prongs as well. So as I said before, we would intubate the baby in the delivery room only if it is persistent respiratory distress, significantly increasing FiO2, difficult to maintain saturations, recurrent apnea, and that would be the time to intubate the babies. But then once the baby is just on CPAP and we find there is some increase in clinical condition, we find that the baby has less respiratory distress, decrease in oxygen requirement, we back off. We may even come down on the CPAP requirements on the FiO2, the blood gases are well maintained. The target carbon dioxide is 40 to 60 millimeters mercury, pH is 7.25 to 7.35. And if there is good radiological improvement, when we feel the X-ray showing good signs of rib expansion, we may not even give surfactant to this baby, though we keep it standby. But on the other hand, if the respiratory distress increases, CPAP requirements are more than 7 centimeters, FiO2 is more than 30–40%, saturations are not getting easily maintained, we are given caffeine to this baby, we are therefore keen to therefore give surfactant to this baby, preferably animal-derived and porcine surfactant. As I mentioned earlier, 200 mg per kilo. Ideal would be to give it by Lisa technique with a thin catheter. We sometimes don't get the regular catheter, Lisa catheters, which are not easily available, neither the AngioCats. We are using orogastric tubes, which are available easily, cheaply in this country, and it has served the purpose. Sometimes, if you're not easy to intubate, you can try a laryngeal mask airway, but then again, you have to get used to how to use that. We try to give surfactant as early as possible within 2 hours after the baby is born. These are the steps in Lisa which all of us know, and we have been practicing this. I'm sure and I'm sure in the next webinars, we're going to have a full session on surfactant and administration. So post-surfactant, the care is to try to come down on the ventilator support, reduce the FiO2, reduce the pressures which you need to give to the baby, because that will happen. And you need to closely monitor the baby's blood gases and non-invasive monitoring. You can probably extubate to CPAP if you're done INSURE technique. Preferably if you're continuing to ventilate because the FiO2 requirements are still high, go on to volume mode of ventilation. Do not suction the endotracheal tube so that suction on the surfactant doesn't get sucked out. Give a loading dose of caffeine, and then consider NIPPV if CPAP after giving the surfactant fails, can probably give CPAP, NIV. Second dose of surfactant, retreatment criteria are there. If the baby still has oxygen requirements, RDS is there clinically and radiologically, you can probably give a second dose of surfactant. Now we can even think of giving it within 4 to 6 hours. Earlier days, we used to give, thinking it's better to give it after 8 to 12 hours and then monitor the response. So that was as far as extremely preterm babies' respiratory care is concerned. But this is the baby which I think we should all concentrate upon, the late preterm baby, which compromises close to 75% of preterm babies across the world we deal with. These are the babies who, given a good care at the time of birth, can do well. If the baby has respiratory distress, give the baby CPAP. Don't hesitate with a mask or prong, whatever you want. Monitor the saturation. You may find, probably it's transient tachypnea of the newborn, it may settle down, and then get the baby shifted off the CPAP and shifted to the mother, maybe in a few hours. On the contrary, the FiO2 requirements keep increasing. Then you need to know whether it's TTNB or whether it is some RDS. As I said earlier, late preterms have a higher incidence of RDS. You can have pneumonia, you can have a PPHN, you can have spontaneous pneumothorax as well. So you have to be a little careful. So the best thing is to immediately resolve the issue, get an X-ray done, get a lung ultrasound done, do a septic workup if you are suspecting sepsis, and if you're suspecting pneumothorax, again, go to using a transmission and then follow up these babies. So the treatment subsequently depends on what you get. If the baby has got IDS, the same protocols you can follow: sepsis, treat the sepsis; pneumothorax, drain it; pulmonary hypertension needs to be treated towards the goal direction, towards PPHN; surgical. Sometimes you may be very surprised, and I have had multiple surprises like this, that you find a CDH, diaphragmatic hernia, or a CCAM, which you think was just not diagnosed antenatally, or probably it was missed, and you therefore need to involve a surgeon after that. Typically in meconium aspiration, the same protocol follows, but these babies are a little difficult cup of tea. They don't really settle down fast. And if it is really bad meconium, it is going to increase. The respiratory score is going to keep increasing. The work of breathing, the blood gases are going to deteriorate. You have to have a good ventilation facility available. If you think you don't have facilities, you're in a level 1 setup, you need to transport this baby soon as possible. In the NICU's tertiary care, they will probably be ventilating these babies with prolonged expiratory times, because these babies have a long time constant, and these babies can have a higher chance of auto-PEEP, and they can blow their pneumothorax with air leak syndromes if you use very high pressures, and if you don't allow enough time for expiration. So these strategies, I'm sure, will be discussed in the next few webinar series. This child, of course, the same protocols of management will happen. Surfactant, sometimes if required, can be given. Antibiotics, pulmonary vasodilator therapy based on the echocardiographic findings, high frequency modes if the child is not improving on conventional, and blood gases, and then the standard protocols of weaning. The newborn with the congenital diaphragmatic hernia, luckily for us in a tertiary care unit, 99% of the times we know this baby has gone to be born with a CDH, is antenatally referred to us. But if you find a baby not responding to resuscitation at the time of birth, and the child has probably got a very scaphoid, flat abdomen, you have to definitely intubate this baby, positive pressure ventilation, and then look at the X-ray, try to see whether conventional will work, but then high frequency not necessarily all the times works. These are European guidelines published about 4 years back, can do well with conventional ventilation itself. And then you may probably closely monitor and decide whether surfactant needs to be given, especially if the lungs are bad, weeks and you may give surfactant. Hemodynamic assessment, pediatric surgeons only will operate once the child is hemodynamically stable and the child's pulmonary hypertension slightly better. Maybe after 48 hours after the birth, they may decide. And of course, supportive care. Now, this is a different cup of tea, and these are the babies you're most scared about. The baby is delivered, comes back to you, or the baby is in the ward and has respiratory distress like this baby, or the baby has been referred to you, comes from outside, outbound. You need to decide when the baby comes with respiratory distress, whether it's a preterm or a term in the emergency, or I typically tell my doctors, check the gestation history-wise, and also check clinically whether the baby looks preterm or term, because naturally the causes may be different in preterm and term. The age of presentation, if the baby is just born and referred immediately to you, or the baby is like this, who's gone to the ward and then subsequently comes back to respiratory distress to your nursery, the causes may be even aspiration, the causes can be infection. You have to decide also whether it's a sudden presentation, maybe a choking spell triggered it off, an acute life-threatening event triggered it off, or it could be a gradual insidious onset of respiratory distress. For example, the good diaphragmatic hernias, which don't easily get picked up in the antenatal scans, which have actually a very good prognosis. They may be born with a good respiratory drive, and then slowly they start getting worsened. That's one thing. Sometimes you may have cystic lesions in the lungs like CCAM, which can worsen insidiously. So good antenatal histories is very important. Antenatal scans to decide whether CDH had been picked up. Any history of birth asphyxia, perinatal risk score, and risk factors for sepsis. Especially in current pandemic times, we had to check whether there's been fever, cough, and cold in any relatives. Meconium history you had to check, and that could be also a reason for slowly worsening. So these babies, once they deliver, they're actually more a concern for when they come to you. Typically, the baby is apneic, gasping. There's no question. You have to train your residents. You have to intubate the baby and ventilate this baby. Like this baby with a very bad swelling in the neck who delivers elsewhere and comes to you gasping. This child is a very difficult kind of baby to intubate. Sometimes we use a video laryngoscope also to intubate these babies. Look at cyanosis, peripheral, central cyanosis, respiratory distress scoring, the work of breathing, and you can even assess clinically whether this baby is going into respiratory failure. You can even electively intubate and stabilize this baby. You have to decide whether it's an upper airway problem or a lower airway problem. The pattern of breathing can tell you if it is substernal and suprasternal, it's probably upper airway and you need to be sure. Sometimes a noisy breathing can give you a clue. If there's a stridor, a grunt, or a nose block, or a wheeze, that can tell you where is the block, where is the problem here. We always ask our residents to palpate the femoral pulses just to make sure it is not a ductus dependent lesion which is getting worse, or it should not be a coarctation which is probably presenting. Babies can present with cardiac problems or septic shock. You have to check the capillary filling time, the perfusion, the pulse volume. Hypothermia can also cause respiratory distress. We should not forget that. We should also look at the child for dehydration, and it could be just an acidotic breathing the child has got. As I mentioned earlier, it could be a diaphragmatic hernia. Look at the abdomen where it's soft and probably very, very scaphoid. So when you have a baby who's breathing with a noise, it could be a stutter. Typically, the sound is like that, as you can hear that. That is probably coming from the pharyngeal area above the larynx. And it could be also due to nasopharyngeal obstruction. You have to look at causes there. On the other hand, if it's a stridor, we are all used to seeing stridor. Most of the time, it's a laryngomalacia, or it could be as ominous as a subglottic stenosis also, or a vascular ring also. Sometimes it could be wheezing. You can actually hear wheezing in babies with meconium, bronchiolitis, and pneumonias. And grunting, of course, is a compensatory mechanism for the glottis trying to open the lungs, in especially RDS in preterms and TTNB. So that gives you some clue to the baby's respiratory problem. So the initial assessment here is very important. Don't forget glucose, because hypoglycemia can cause definitely respiratory distress, hypothermia also. So you add to the point of care assessment in the delivery room or in your receiving room in the emergency. You can keep an advanced elimination available kit available with you. Lung ultrasound, you can do it there itself. You should be able to do a screening echo. And more of us, while doing screening echoes, are able to determine whether there's a gross congenital cardiac anomaly. Like yesterday, even my residents could make out there was something very fishy in the heart, and it looked like a truncus arteriosus the baby had come in with. But typically, we would look at whether the cardiac contractility is good. The child has some evidence of pulmonary hypertension. That is something you have to look for. Rapidly, you can do a cranial ultrasound, look for a bleed that can also cause respiratory distress. We have this wonderful ISTAT facilities now available in most emergencies. You can look at the lactate, which is a sign of tissue hypoxia. And if the lactate is more than 2, you know the tissue oxygenation is not good, hypoxia is happening, this child is getting worse. Electrolytes can be checked. You can have the bicarb assessment also through that. And polycythemia can pick up through an ISTAT in the emergency room. Apart from that, you're waiting for an X-ray chest portable. If you have evidence of pneumonia, your diagnosis is made. Sometimes there's a confusion, like this baby could be pneumonia or could be a late presenter of RDS who's sitting at a nursing home and slowly gets breathless, and the doctor refers to you. You're not sure whether it's pneumonia or RDS. You can have cysts in the chest, which are easily seen. You can have a diaphragmatic hernia seen. If you're not sure whether this is pneumothorax or something else, you can instantly do an ultrasound like this baby we did, and we found barcode sign suggestive of pneumothorax, and we put in a chest tube. You can have a baby presenting a severe respiratory distress, getting treated at another hospital and not getting better, pneumonia, and you find that it may be a bad pneumonia after all, maybe fungal pneumonia or the newer viruses which are floating around. So an X-ray chest is absolutely necessary, portable. The other thing we would always encourage our residents to do is a hyperoxia test. You give 100% oxygen for 10 minutes to decide whether there is congenital cyanotic heart disease or a pulmonary hypertension with a right to left shunting or a pulmonary disease. In a pulmonary disease, if the resident does a blood gas, the PaO2 after 10 minutes of 100% oxygen will be always more than 150, whereas it will be less than 150 in a cyanotic congenital heart disease or a pulmonary hypertension. But then the gold standard is also important. You have to get a cardiologist to come and do an echo, rule out in respiratory distress, ductus dependent lesions. You would of course need to do septic screening for these babies, start antibiotics if you think it is positive. As Nilesh presented wonderfully day before yesterday, you need to do a wonderful do a metabolic screening. We have picked up so many babies of MSUD, citrullinemias, and methylmalonic acidemias who are just presented with respiratory distress. You have to, of course, do higher tests like a laryngoscopy or a bronchoscopy. Like this baby with severe respiratory distress, you can see the upper airway type of issue. You stabilize this baby, but then you have to probably engage your pulmonologist and do an endotracheal, do a bronchoscopy or a laryngoscopy. You find in this baby, the lower trachea, there was slit-like appearance. We got a CT scan done and you find there is a prevertebral abscess. In a 21-day baby, this prevertebral abscess was drained by a thoracotomy and the child recovered well. It was MRSA, such a surprise. The baby had been sitting at home with hardly any symptoms and then got symptomatic only for 3 days and came to us with severe stridor. For example, these babies who also come with stridor, you have to remember that an upper airway and a lower airway evaluation is very much essential, because you may, to your surprise, find, like in this baby, we found a laryngeal hemangioma almost extending to the lower trachea. This baby did well with propranolol because we couldn't do anything otherwise intervention. So this baby did well with propranolol therapy, was requiring ventilation for nearly 2 months, and this baby did well. We have now the facilities of trying to do CT scans. CT scans can show collapse consolidations or pulmonary hyperplasia, sometimes like these X-ray CTs you see here. You have babies presenting with upper airway issues with a big swelling there. You don't know what it is, whether it's a cystic hygroma or it's a hemangioma. This baby turned out to be a hemangioma, though it is compromising the airway. We ventilated the baby and gave propranolol, and the hemangioma just shrank and the baby could be extubated. There's another baby who had, now this is where ultrasound technology is fantastic. You can do an ultrasound, and this is the lower airway, mind you. Here on the left side, you can see the trachea is collapsing, and this baby had a mid-tracheal malacia. This baby required ventilation for some time and luckily got away. Otherwise, we were thinking of doing some surgical intervention for this baby. Sometimes, lo and behold, you do an echo thinking it is just a preterm with RDS, and you find this baby has respiratory problem because of a tumor in the atrium. And this baby had a rhabdomyoma. Of course, luckily for the baby, it disappeared on its own, which most of them do, and we could give a good prognosis to this baby. So in the end of my lecture, what I wanted to say is, we have a protocol-driven kind of approach to RDS like this, combined with good supportive care. These are all now the guidelines which are published, and you were able to support these babies. I think the outcome is going to be fantastic. Thank you so much. I am really very overwhelmed by the support my teachers have given me, my students have given me, my colleagues, friends in the NICU, my nurses especially, and above all, my parents and my family and the patients who have imposed so much trust on me. Because neonatal intensive care of this nature requires a lot of support and a great teamwork. Thank you so much. I'm very happy to answer any questions if there are any. Thank you so much.
Thank you very much, sir. So I request Dr. Sidhu.
Yeah, Prashant, thank you. Hope I'm audible, right?
Yeah, speak a little louder.
Yeah, sure. Good evening, Karthik sir. Good evening, sir. It was a wonderful discussion and a great talk, sir. I think you have elaborated most of the things, and only hardly few questions we have left. First, we'll start with Dr. Sunil, sir.
Yes, sir.
Sir, you are available, sir?
I'm available.
Yeah.
1 minute, Sidhu. I will just stop sharing 1 minute.
Yes,
I'll just stop sharing. Yes, I stopped sharing now. Yeah.
Yes, sir. Yes, sir.
Yeah. Thank you.
Sunil, sir, what is the role of non-invasive PPV in apnea, sir? In preterm neonates with apnea, is there any role, defined role as of now?
That's what. First, usually they're using CPAP and high frequency nasal cannula. A lot of studies of NIPP. Recently in 2015, the synchronized NIPP is more effective than the conventional CPAP.
I think Prashant, Sunil sir's audio is little.
Hello, can you hear me?
Yes, sir. Yes, sir. Can you repeat it, sir? It was not audible to the people, sir.
Usually, commonly we use high frequency nasal cannula, CPAP and HFNC.
Yes, sir. Yes, sir.
The question was whether use of PPV is there.
Yes, yes. Non-invasive PPV, is it a better evidence right now, currently?
2015 article shows that the flow synchronized non-invasive PPV has a better effect than the conventional CPAP or NIPPV.
Okay. Next question, sir. It is from postgraduate from Gulbarga Medical College. He wants to know, is there any role of prophylactic methylxanthines in preterm neonates, especially less than 28 weeks?
That's what cornerstone is methylxanthin only. Now, earlier, what used to 28 weeks or 29 weeks after the apnea start used to give caffeine or any methylxanthin. Now,
Yes,
immediately after delivery, because it has have some effects like reducing the mechanical ventilation duration, incidence of BPD has decreased, neurodevelopment is good. We are using early caffeine system.
actually, caffeine is preferred. That's what you're trying to say, sir, compared to methylxanthins, right?
Yes.
Okay. And according to your experience, what could be the most common cause for persistent apnea, sir? You defined it really well. Any other common cause you have come across, sir, for the persistent apnea in neonates?
Persistent apnea, commonly we usually see in NSUG sepsis. Otherwise, commonly we are not much encountered with other commonest cause.
Okay. Okay. What about the role of gastroesophageal reflex, sir, in persistent apnea?
This what it's called laryngeochemo reflex. What is told? There is an association between gastroesophageal reflex and the apnea of prematurity is there. But thing is, it has not been clear. It is a causative agent.
Mm-hmm.
Still, a lot of studies is required that, and also some studies have shown that GR there is no AOP. Therefore, we can't tell GR. In fact, will have apnea of prematurity at this point.
Okay. Okay. Sir, one fellow has question. Is there anything called CPAP apnea, sir?
CPAP apnea, I don't know the term, but probably clinical thing is on CPAP, if the obstruction is there, they are not done suction and all, they may have obstructive apnea features may be there.
Okay. Basically, it's because of the mechanical obstruction. You're trying to say there will be apnea immediately following CPAP.
I have not heard about CPAP. If anybody audience know or Karthik,
Dr. Dinkar, sir, you would like to add anything? Prashant, I think you have to unmute Dinkar, sir.
Sidhu?
Yes, sir. Anything you would like to add in terms of CPAP apnea, sir?
CPAP apnea. Yes, there is a term called CPAP apnea. It is called when the apnea, I mean, when we put the baby on CPAP, because CPAP in that machine, the expiration is usually passive.
Yes,
passive. Sir. Either you will put on NIPPV mode or synchronized NIPPV mode or CPAP mode. All those things are expiration is passive only. Number one. During that time, what happens? Inadvertent PEP might develop. Okay. Because of that, what happens? Stretch muscles in the lungs, stretch muscles in the chest wall will stretch. It will sense it and signal it to the central brain. Okay. So that will signal the, respiratory center to go for a apnea because it is maximum FRC is attained. Okay. So that is the reason, even if the pressure is too much, baby will go for a apnea because of inadvertent PEP. That is called CPAP apnea. It is not only due to the obstruction. It is due to the stretch receptor. Okay. That is the reason there are newer things has developed called synchronized. What is that? NIPPV. That is also become now old. Number one. Now the second thing. I think so. You are hearing, Sidhu?
Yes, sir. Yes, sir. You are audible, sir. Please go on.
Okay. So number one. Number second thing. That is also now outdated. Now it has come as an NAVA ventilator. NAVA. Okay, so that is called neuronally adjusted ventilator. In that, what happens? That CPAP apnea word, whatever it was there, it is now outdated. Even with that is also little tricky and little invasive procedure, like putting the esophagus. That is what is that EDI? That EDI means diaphragmatic electrical activity. That EDI, that is NAVA level. What is there? What we will tell. If it is, it is very expensive. Servo N. Now it has come like an HFOV. That high frequency either interrupted or oscillatory ventilator, non-invasive. It is more convenient, more better. That is not there. What is that? CPAP, apnea, or apneic spells.
Okay.
Even on CPAP, what we will prevent for apnea, that might itself will cause it. That is the one word what we people should know. Okay, over
Thank
to
you,
Sidhu.
sir. Thank you, sir. Thank you, sir. Sunil, sir, I think you have answered this, but one of our postgraduate has put again. When do you would like to stop caffeine, sir, in a preterm who is 28 weeker? I think you have answered this in your slides, but can you please repeat it for them, sir?
Weeks are when there is no apnea free period for 5 to 7 days on full feed the baby usually we do, but nowadays what they are doing because of intermittent hypoxia containing for 38 weeks to 40 weeks may be good in for neurodevelopmental outcome.
Okay, thank you, sir. Now I'll move on to Karthik Nagesh, sir. So good evening, sir.
Hi, Sidhu.
Yeah, so first question we have from Dr. Asha Dur. I think Madam has asked what are the cutoff standards for surfactant for a baby with 32 weeks with who has been on complete course of antenatal steroids, sir?
Cutoff in the sense, I mentioned it, the
Yes, sir.
current
Yes, sir.
cutoff is 30%. In babies who are 28 weeks and less is 30% FiO2 on a CPAP of 5.
Yes,
and babies who are older than that, you can wait till 40% of FiO2.
Okay, okay. It's between older babies for 40% and the other one is 30%, sir.
Yes.
Yeah, we have one question from Sanjeev Rao Joshi, sir. How do you treat a baby if X-ray is confusing between HMD and congenital pneumonia?
See, the treatment in terms of respiratory support is still the same. Basically, there's no difference. You will have to go according to the need. If the child is getting worse and respiratory failure is coming up, then you need to even ventilate this baby going on from CPAP. The decision is about giving surfactant, but then there's enough data now available that even in congenital pneumonia, surfactant works. So if there are still doubts in your mind, you can easily, and especially if the history tells you it's a preterm baby, and steroid did not at all or not given full course, you can probably go ahead and give surfactant to this baby.
Okay, I think we have 3 questions on surfactant itself, sir. I think you would be happy to answer that.
Yeah,
one is preferred surfactant according to you, sir. You have already said it's bovine surfactant. Anything more to add, sir? Sorry, sir.
Sidhu, sorry.
Porcine, sir. Porcine surfactant.
Porcine,
you want to add on that, sir.
The surfactant, a lot of data has suggested, as I said, it's natural surfactant, which is animal-derived surfactant, which is more preferred than synthetic surfactant. That is one thing.
Yes, sir.
Surfactant, in terms of volume, the porcine surfactant dose, no doubt, is on the higher side, but it becomes a less volume. Probably in the 2004, early 2000s, when the data was compared between poractant, which is porcine surfactant, versus the bovine surfactant, they had used a dose of 200 mg per kilo and looked at the oxygenation. They found the oxygenation was better, but those are the only trials which have been really published comparing the bovine surfactant and the porcine surfactant. And a lot of follow-up data has shown that in this dose, it works well and the child's incidence of BPD is much lesser and the incidence of ventilation is lesser. So porcine it is, and the dose of 200 mg per kilo. That is the recommendation.
Okay, sir. Thank you, sir. According to you, the preferred mode, sir, right now, practically what
preferred
you
mode
practice?
As of just now, if the unit is quite sort of capable of handling it, less invasive surfactant is the best way to give it. In fact, I myself was skeptical that people like me, whether I myself would be able to do it, but of late we have started doing that, and I find it's a good way and easy to do. It should be the best way to do it.
Okay, thank you, sir. And your experience or any study about the nebulized surfactant you have come across, sir?
No, Sidhu. Actually, nebulized surfactant, there's a kind of rider to it. It's not coming up immediately because the particular nebulizer, which is called the vibrating mesh nebulizer, it's a different type of nebulizer. It's very expensive, and otherwise surfactant gets wasted and it doesn't get easily deposited inside the lung. Most of the data suggests that only about in the regular nebulizers, only about 15% of the surfactant will reach the lungs, but in a vibrating mesh nebulizer, most of the surfactant, 80% will go into the lungs. But I think still we'll have to wait for the thing to come.
Okay. I think one more question we have got, sir, from Dr. Asha. Role of surfactant in pulmonary hemorrhage, sir?
Absolutely, yes. You should. If you have stabilized the child, luckily, and the child is more stable, you should give surfactant to the baby.
Okay. One question from Facebook, sir. I think you have answered this. your experience on budesonide along with surfactant in CLD, sir?
Actually, we have not still started using anything like that right now. We are still, by God's grace, for whatever reason, the risk of CLD is not much in units like us. Probably we are dealing with, in this country as such, also we're dealing with babies a little bigger in weight.
Yes, sir.
We are not looking at most of the times about 400 grams or 500 grams. So the risk of BPD is not really happening to be increasingly seen. But nevertheless, I would look forward to more papers, and meta-analysis is available now. Cochrane database is there. So probably we should just think about it if this situation is bad.
Sure, sir. I think you've answered that question on missed already. I think it was a repeat question. How late can we give surfactant, sir?
Yes, it's a very important question. Good question. Typically, we have to understand the pathophysiology. Inside the lung, when there's hyaline membrane disease, there's a lot of protein leak. There's a lot of capillary leak inside. So proteinaceous fluid from the interstitium goes and gets filled up inside the alveoli.
Yes,
So
sir.
this becomes the reason why surfactant may or may not work, even if you give it very late. So there's a lot of inflammation already in the lung. The child is probably in hypoxic ischemic respiratory failure. So more acidosis is occurring, hypercarbia is there. So endogenous surfactant is also not getting formed. So the child comes late to you, more than 24 hours of age, it may not work. On the other hand, the child may deteriorate. So this would be something you'll have to think. You should not give surfactant. There's no recommendation to give.
Okay. I'll move to Sunil sir. Sir, two questions for Sunil sir. Sunil sir, are you there? Yeah. Sunil sir. Prashant? Can you unmute Sunil sir?
One second.
Yeah.
I think he's there. 1 second. Yeah.
Sunil sir? Okay, I'll continue with Karthik sir till Sunil sir comes. I think there is one more repeat question, sir. What is your preference of choice for a non-invasive respiratory support in a term baby with RDS, sir?
CPAP. It is CPAP only. Because the respiratory drive is going to be good. You can start with a CPAP of about 6 centimeters of water and go on to even 8 centimeters of water. Absolutely. CPAP.
Probably they wanted to know what is the role of HFNC, sir. I think it was a postgraduate from Hubli.
No. No, HFNC, maybe you can, but I still think as a primary support, CPAP is the best.
Sir, one question we have about the antenatal diagnosis. How do we differentiate between CCAM and congenital lobar emphysema, sir? Would you like to take that?
Say, antenatal diagnosis, I would leave it to the fetal consultant. But CCAM is a cystic. Basically, I agree. If it's a very large cyst, it can almost look like congenital lobar emphysema. I think the fetal MRIs people do. I don't know whether that will pick it up, but I have to check it out. But after birth, I think urgently we can arrange a CT scan or modalities like an MRI are available. I'm not sure whether such a large CCAM is so large that it almost resembles like a CLA. We may not be able to easily miss it.
Okay. One more question we have, sir. How do we differentiate between pulmonary sequestration and CCAM, sir? Any clinical clue or X-ray or any other preferred mode of investigation as such?
I think we'll have to go for a. I'm
MRI.
not sure. We'll have to check it out. Maybe an MR angiogram or something. I'm not still sure about it. I'm sorry about that.
Okay. Dr. Dinkar, sir, would you like to add something?
Yeah, it is very difficult, my dear. You know why? CCAM or whatever broncho sequestration, bronchopulmonary sequestration, it is really difficult, my dear, because even antenatally also the people do diagnose, even CCAM or BPS, because BPS is, I think so, it is a extra pulmonary tissue is growing. CCAM is in the alveoli, whatever adenomatoid cells are there, it is abnormally or dysplastically developed, causing the mass. That is one thing everybody knows here. The thing is, everybody knows one thing is, it is unilateral. Both are almost left side only, lower lobe, like a CLE is a left upper lobe. This is a lower lobes. Both are the same thing present. And the one thing is how to do it, how to do, I don't know really. Both are usually, what is that? Males are more common. That is also I know. But other things really I don't know, dear.
Diagnostic, diagnostic of pulmonary sequestration CCAM is the angio, as Karthik sir was there. There will be separate vessel which differentiates the sequestration from CCAM. That's the diagnostic.
Yeah, because
I think
BPS
Sunil sir is adding on to it. Thank
other
you, sir.
than pulmonary. Other than pulmonary. CCAM is in the lungs.
Yes. As sir was telling, that the only differentiating is the angio, where the separate vessel to the lung is there. It's the confirmatory of sequestration.
Okay.
Very clear. Very clear. Sunil, correct.
Thank you. Sunil sir, we have few questions for you as well. Why apnea of prematurity usually doesn't manifest in the first 24 hours of life, sir?
Oh,
I was just thinking, nice question.
This was one conference, same question was asked. The answer was not there. What they told, the hypothesis is there. This is mainly because of the central mechanism of the pathway of stimulation. Respiratory stimulation is the one which may be present with 24 hours. But exactly, there is no reason why it was not present with 24 hours. This is the hypothesis they have told actually.
Okay. Sir, what about Doxapram brand, and is it available in India, sir?
We have used especially how we have used is central apnea syndromes, hypoventilation syndrome. Since it is not responding to apnea on ventilation, we have used 2-3 cases. We are according to my experience.
Brand name, sir. Is it available in India, and brand name?
It's available. Since recently I have not used in KIMS, I don't remember the brand name, but it's available.
Okay. Thank you. I think we have few questions for Karthik sir again. Sir, I think what is the time interval between redosing of surfactant, or how much time can we wait? From Murali Rajan, sir.
No, the same thing I have mentioned it. Earlier we used to even wait till 8 to 12 hours. Now, recent data suggests you can give it at 4 to 6 hours. If you don't find that RDS is improving and the FiO2 is more than 30%, there is a lower threshold. There are 2 thresholds you can keep in your unit as a unit policy, that if it increases to more than 40% FiO2, only then you redose, or you can even keep it at 30%, which is smaller BB. That would what I would even say 6 hours should be optimal.
Okay, great, sir. Sir, any practical guidelines for alveolar capillary dysplasia, sir, in your experience, prognosis-wise, from Dr. Vardhan Patel?
Yeah, we actually had the, I would say, the misfortune of looking after an alveolar capillary dysplasia. This baby was born and referred to us after the original hospital had done everything for that baby. They referred thinking maybe it was something unusual. So we also ventilated, gave nitric oxide, did all kinds of aggressive treatments. HRCT did not pick up anything which was something else likely. So finally, unfortunately, the baby succumbed, and this baby, we got a post-mortem diagnosis of alveolar capillary dysplasia. We actually published it about 5 years back. Alveolar capillary dysplasia is almost 100% mortality. Unless you are planning to do a heart-lung transplantation, which is not available anyway in this country. It is not an antenatal diagnosis. It's not a diagnosis in the living child we can offer, because lung biopsy is not something you can easily do it in a living child who's requiring a lot of ventilation. So this child had to be sort of subjected to a post-mortem lung biopsy, and then it was confirmed. But it's a bad prognosis. It's really nothing much. And it was a genetic. You had to identify the gene. We had in this baby identified the gene for the next pregnancy so that prenatal counseling can be done. But it's a bad prognosis.
We have one question for Sunil sir. How do you manage a case of pontocerebellar hypoplasia associated apnea? Oh, Dr. Hashadur. Sunil sir.
What is that? What is that once again?
Pontocerebellar hypoplasia associated apnea. Pontocerebellar hypoplasia associated apnea for Sunil sir.
Probably one of the cause for central hypoventilation syndrome. Clinically, we are not you will not see actually.
Yes, sir.
Baby will be on prolonged ventilation. But since the central cause is there, we can't help much. Only you have to try with doxapram and Apnea. If it works, is good. Otherwise, I don't have much experience on what cause they have told.
Yes, sir, that diagnosis itself was interesting, sir. Karthik sir, you want to add anything to that, sir, please?
No, it does seem to be some kind of cerebellar dysgenesis or something.
Yes,
It's a
sir,
bad
yes, sir.
prognosis. It's a cause of central apnea. I am not sure, but it's more an academic thing. Ultimately, it may not affect the prognosis. Long-term prognosis may be bad.
Okay, okay. Sir, one question from Punjab, sir. Transcutaneous carbon dioxide measurement, any evidence or updates currently we have?
See, I mentioned it briefly. Earlier
Yes,
days, you would not believe it, but when I was a student doing my MD, I was in Chandigarh exposed to TCPO2. Those days, we used to have a heated electrode, which would be kept on the baby's abdomen, typically on the right hypochondrium with a temperature of 43 to 44 degrees centigrade. The principle is it heats up and causes vasodilatation in that area so that the blood vessels there get arterialized, and therefore the carbon dioxide molecules diffuse out into the skin onto the electrode. There is a gel there. Through that, it goes onto the electrode, and then it is detected what is the carbon dioxide level, which is almost similar to the arterial blood carbon dioxide. A little bit higher because there's a little bit of vasodilatation there. And also because of the heating of the electrode there on the skin, there is a little bit of CO2 production is more because metabolism is more. So you get a report of CO2 about 4 to 5 millimeters mercury more than the arterial blood gas actually. So a very good way for continuous carbon dioxide monitoring. Only thing is the electrode gets heated up and therefore you have to keep changing and it causes skin blisters. So in extreme preterm babies, it's a little difficult to use it. Inexpensive, so I don't think it's inexpensive, it's very expensive. The electrodes also need to be changed. The best is now you have capnography available. End-tidal carbon dioxide is good enough because alveolar ventilation is easily reflected by the end-tidal carbon dioxide. Now, recently, some companies have demonstrated to us even non-invasive ventilation modes. You can have a side stream sampler for a capnogram, which is available even in Bangalore. It's available now. So that is one other thing we can use. It gives a fairly good indication of the CO2 for enough monitoring on a long-term basis. So I don't think the transcutaneous CO2 is very, right now, a kind of necessary thing. It's a good modality.
Sure, sir.
Hello.
I think, yeah.
Sidhu?
Yes, sir, please. Go on, sir.
To Dr. Karthik Nagesh, sir. See, Suntech method, America, Suntech method, the people who have found out other than oscillometric BP checkup, which is more accurate because oscillometric means during the deflammation time, we will check the BP. They are the company, they bought out for the neonates, transcutaneous CO2, two methods they bought out. Number one is gas without gas. So with gas, they will quote 17.5 lakhs. They will bring down to 9 lakhs. With gas, without gas is little expensive. They will tell 20, they will come to 11 lakhs. So that is compared to the what at present 4.5 lakhs transcutaneous CO2, what it is available. So that will emit definitely heat, that will cause blisters. What these people have brought out without any temperature, and only thing is even with gas, that is also very low, consumables are little expensive, 9 lakhs. Suntech method, in case if anybody wants to buy that, you can go to the internet, you can go Suntech method, transcutaneous CO2. It is available because I have seen it in the Dubai just in the January month, and it is available since 1 year, 1.5 years in America. You people can check it out.
Thank you, sir. Thank you, sir. Thank you for the information.
Thank
I think Dr. Pratap Chandra has got a experience to share. Yes, Pratap, over to you, Pratap. You wanted to say something.
Good evening, sir. Karthik sir and Sunil sir, extremely good presentation. I think you've got mixture of, amazing experience, put into that. I think that oozes in that presentation, Sir Karthik sir, especially. I just wanted to add one thing about the transcutaneous CO2. So we had huge experience of this in UK, especially as you said, rightly said, extreme preterms, they can induce, skin burn. But in the term babies, especially when you're using the high frequency oscillation, because the oscillation or the jet ventilation is extremely good in removing the CO2s. So these are the instances where I think we as consultants never, let go of the junior doctors if they don't use that, transcutaneous CO2. So that is probably in term babies, if you keep changing the position frequently, it should not cause too much of burn. So that is our experience. Second thing, sir, I would like you to discuss the usage of, nebulized Budicort, early nebulized Budicort in extreme preterm babies in the prevention of chronic lung disease. As we say that, we have already started using this for the last 1 year. We've had some good results. So I just wanted both of you to see whether you can share your experience, especially in extreme preterm babies.
Actually, Pratap, thank you for bringing that up, but I think there's a good session on BPD in the coming days to come, which I'm sure there's a lot of changes in the thinking on BPD, and we have been having the luxury of having most of our babies delivered in our hospital getting antenatally steroided. So our incidence of BPD is not really too much, but in the babies whom we suspect there may be a possibility of early BPD developing, probably we would definitely think of it, especially in the early end of the first week or the first 10 days or so. We would, rather than giving a course of postnatal dexamethasone or even hydrocortisone, I would bat for giving Budicort nebulizations, but not much experience really. I have not had much experience. That is also good in a way because our BPD rates are not yet too much. As I mentioned earlier, we have had, as I can count on my fingers, this last 3-4 years, at least maybe only about 6-7 babies having had really classical BPD. We have not had, luckily, too much BPD.
So this I was quoting the evidence from New England Journal of Medicine, where usage of Budicort in dosage of 400 to from the until this definitely we're doing the chronic lung disease might bring in. Unfortunately, sir, I think we are getting so many babies from outside without steroids and things. Our rates of BPD are very high in our unit. So that's one of the reasons why we started using this.
Good. Yeah, it's a good idea.
Okay. I think Prashant, the Dr. Subramania sir has raised his hand. Yeah.
Good evening, Dr. Karthik. It was wonderful to listen to you people. And I thought it would be appropriate if I would just come in for one point of where the discussion went on about congenital lung diseases and antenatal scan and thereafter newborn period. Although we don't have much experience of antenatal and early neonatal presentations because you people are better in daily contemplating, I have only a couple of points to make. One is that none of them generally present with any emergencies as such, because most of them will be just space occupying. The knowledge of them would be helpful as differential diagnosis because they may be mistaken for other diseases. For example, even diaphragmatic hernia, the dilated loops can be mistaken for something else, and it can happen. That is point number one. Point number two, which I wanted to tell, is that there is no hurry to differentiate a CCAM, and you have 4 or 5 types of CCAM, and in sequestration we have extralobar and intralobar sequestrations, and they are all important from management perspective, and there is no hurry to make a diagnosis. Like if I were to give some simile, it is similar to antenatal diagnosis of hydroureters or hydronephrosis. You have to just wait, and later on, once the neonatal period is over, one can always follow it up with the respective pediatrician and investigate. The investigation of choice would be CT of the lung, and Generally, MRI is not preferred for lungs compared to CT, and MRI can be only for pre-op if at all surgeon prefers, but most of the surgeons operate with CT reports itself. Aortogram or CT angio is the investigation of choice for extralobar sequestrations, because usually you need to document and demonstrate the feeding vessel, because that's how we are going to operate. And the CCAM can be tackled little later on once the child is fit for surgery or whatever, within inverted commas, when the other conditions are fine. So these are a couple of inputs from my side. Congenital lobar emphysema looks like space occupying. It may herniate to the other side, but generally the respiratory distress won't happen because of the lesions themselves. But if they catch up any colds, or if they get bronchiolitis in early infancy, the diseases can be severe and demanding oxygen more. So from these perspective, we have to just think. These are my inputs. Thank you.
Thank you, sir. Thank you for adding those. I think,
And-
Prashant, we have one more person who has raised hand.
Yeah, Patricia, sir. Sir, our president NNF Karnataka chapter.
Oh,
Sir, over to you, sir.
Hello, Prashant and Dr. Sidhu Cherki.
Good evening, sir. Good evening, sir.
And there are no words to Dr. KARTHIK Nagesh. He is the superior in this as far as newborn is concerned. His narration of asphyxiated babies and CPAP and as well as surfactant therapy very well has been narrated, even including the congenital anomalies. And I appreciate the NNF members like Sidhu Cherki and Prashant. They are doing a wonderful job, though I am a remote place. And I'm very thankful for Dr. Sunil and Dr. KARTHIK Nagesh and their involvement for the NNF Karnataka. Very nice, sir. Thank you once again. Over to Prashant.
I think, Prashant, we have Dr. Guruprasad sir as well.
Yes.
Good evening, sir.
Yes. Guru sir is there.
Yes. Sir.
Hello.
Good evening, sir. Good evening, sir.
Good evening. Yeah. I just nothing, no questions, Prashant and Dinakar. KARTHIK, I am audible to you?
Yes. Yeah.
KARTHIK,
Correct.
wonderful presentation.
Thank you.
Yes,
Thank you.
KARTHIK Nagesh. I still remember in 90s when the surfactants use started in the country. Because you yourself and then Arvind Shanai, who initiated the whole surfactant movement for RDS, and subsequently it has become the standard of care for RDS along with CPAP. Wonderful presentation.
Thank you.
Neonatology should remember. Hats off to Dr. KARTHIK, who brought and made availability of surfactant very easily across the state and across the country. I remember even when we were trained in Chandigarh at that time, surfactant was just started. Even before that, Dr. KARTHIK was using surfactant in Manipal Hospital. We still cherish your initial efforts of procuring surfactant and treating infants with RDS. I just wanted to thank you. Great presentation.
Thank you. Soon. Thank you.
I think there is one more person who has raised the hands. Let me see if we can. Yeah. I think somebody raised the hands. I don't know the name. It's written as Galaxy A6. Sir, do you have any questions?
Myself, Dr. Naresh Prasad from Dhanbad. How frequently we come across the disorders of the muscles and the disorder of the thoracic cage in neonatal practice?
Yeah. Can I raise this?
Sir, did you get the question?
Yeah.
Yes, sir. Repeat the question.
How frequently we come across disorders of the muscles or the disorders of the bony thoracic cage in the neonatal practice, leading to respiratory distress?
I think sir is asking about this thoracomuscular dystrophies. How frequent it is.
I must confess, luckily, it's very rare, Dr. Prasad. Asphyxiating thoracic dystrophy is what we call the June's dystrophy, is a very devastating condition with almost 100% mortality. And we have probably in this last 30 years I've been practicing here, I've seen only one child with that. So it's not something you should worry about. But as the other condition you mentioned is the neuromuscular disorders we have been seeing. We see myasthenia often once in a while. Sometime back, about 4 or 5 years back, we saw spinal muscular atrophy, and unfortunately, the parents, we got a genetic confirmation done. The parents did not want to continue treatment in the child, though the child was absolutely awake and needed ventilation, but they just took it right away, saying they didn't want to do that. But that we do see often, but thoracic dystrophies, luckily not much. Luckily not much.
Is there any role of airborne machine in the neonatology?
I'm sorry.
Airborne machine, which are using for bronchiolitis.
Yes, yeah, you are absolutely right. Airvo is just an adaptation of the high flow nasal cannula. It is a device which is available to as a portable device. You can use it at home, and for home, we in fact are sending babies home on high flow nasal cannula with chronic lung disease sometimes with an Airvo machine. You can use it. It can be. They have a connection with now the extremely preterm high flow. This OptiFlow machine is available. The catheters are available, so you can connect it to the Airvo also. You can use it, especially areas where you don't have facilities for compressed air which is available, and a child is just on 21%. This can give up to 23% sometimes if the flow is very high. You can use an Airvo machine. It's quite useful. We have sent babies home on an Airvo machine.
So, if you have babies with diffuse cerebral edema, caused a birth asphyxia, and it is causing a respiratory problem in the newborn, what should be done for the cerebral edema or patient? How to manage this patient?
I think this kind of a child, of course, you need to ventilate with whatever modalities of ventilation you have. If the child is showing features of respiratory failure, you need to ventilate. But the thing which now all of us are encouraging is therapeutic cooling. You have to do therapeutic hypothermia for such babies. That's very important. And these kind of babies, in terms of ventilation, you may have to, most of these babies are hypoxic encephalopathy term babies, luckily for us, and therapeutic cooling is probably the best answer for these babies. But I didn't understand your other question, Dr. Naresh. What was it about, Dr. Prasad?
Should we give some drugs to reduce the cerebral edema?
Yes. No, absolutely no. Please remember that the cerebral edema is occurring in hypoxic ischemic encephalopathy because of swelling occurring where the cells have already undergone necrosis, and the cell swelling is because of that. So giving mannitol, giving steroids is just not going to help. It may actually deteriorate the baby's condition. Please don't do that. You need to just give supportive treatments and do therapeutic hypothermia, whole body cooling if it is possible. Please don't do that. Please don't do that.
Sir, how can we get the various apps which has been discussed right now, today also, and then the previous lectures also?
It's available. These mobile apps like Dr. Satish Devpujari has got about 10, 12 apps. It's available on the Android store and the iPhone Play Store, iOS also. It's available. You can use it. It's free also. And the best thing is Dr. Satish Devpujari's app on the ABG is quoted in the Goldsmith textbook of neonatal ventilation also. So it's been adapted in that book also. It's a very good app. Everybody should use that.
So is there any modification in the pulse oximeter, which is available in India? What is best out of that? What is the best pulse oximeter in India?
Yeah. See, I don't want to name any brands, but the SCT technology is the most important. Please understand, pulse oximetry basically depends on trying to differentiate, trying to get during the pulsatile blood flow, trying to find the difference in oxygen saturation between oxygenated hemoglobin, which absorbs the infrared spectrum of the light, and the deoxygenated hemoglobin, which absorbs the red spectrum of the light. So this comparison during the pulse wave of the blood supply gives you the pulse oximetry reading, which is the saturation. But sometimes, since the blood is flowing in the venous circulation also, that also creates some pulses, which gives wrong signals. That is why many times you find baby is sick looking, but the pulse oximetry is still showing some good saturation, or vice versa. Sometimes if the baby's perfusion is not good, you're finding some pulse oximetry signals. So many companies have used what's called the signal extraction technology. They try to take all these signals and filter it out so that only the arterial pulsation signals are gone to the machine and they give the accurate estimate. Now, these kind of devices are very good because in extreme preterms with a blood supply which is very poor in the periphery, they are very hypothermic, perfusion is not good, even then these machines can pick up. So you have to pick up a machine, a pulse oximeter, which is got the SET technology. I think that is the word you have to use, and that's the best for these babies.
Sir, what importance should be given to the blood pressure monitoring in neonatal practice?
Absolutely important. There is no question. If you are dealing with a sick child, blood pressure is important. But then I keep telling my fellows and residents, there are other parameters, and Dr. Naveen Jain in these web series had told very nicely. You have to look at the capillary perfusion. You have to look at the capillary filling time, that is, look at the heart rate of the child, look at the temperature difference between the central core temperature and the peripheral temperature. You can even look at non-invasively functional monitoring. You can look at the cardiac contractility, look at the inferior vena cava, whether it's distensible or contractile. So there are many other ways also assessing. They are also very important to assess the child hemodynamically. Blood pressure is probably the last thing to fall. Many times you get other impressions from the baby. So this critical care monitoring, there should be a protocol you should adopt. You can even train the nurses to look at all these other peripheral parameters, and that will give some idea, including things like mottling is also a very good thing you should look for.
So we have got a lot of equipments in the NICU. How can we disinfect them?
You got a lot of, sorry?
So there are large number of instruments that are used in neonatal practice. How they should be disinfected or sterilized instruments?
Yeah, actually, sir, that point is valid. Since you're running a large NICU, there are very good guidelines published by NNF on their website. And in fact, it's available on the net. You can use, there are different disinfectants required to be disinfecting the critical care equipment, then the equipment which is housing the baby, like the incubators, warmers. There are lots of these things available. I think we can probably request you to see the NNF website. It's available. A lot of NNF publications are available on this.
Thank you, sir. Thank you very much, sir.
Dr. Amit has raised hands, and regarding the cleaning of equipment, all electronic devices, you can clean with bacillocid acid, which is isopropyl propranolol combination. That is the best recommended for all surface cleaning, complete surface cleaning. Dr. Amit?
Yes, sir. I want to ask Karthik, sir, regarding Budecort and surfactant, this combination. How to go about it? As you mentioned that it's found to be effective in BPD. In our setups, how do we go about it? Rather mixing or whatever, or does it come pre-mixed with this?
See, Amit, I must confess, I spoke earlier also, somebody raised this question. I have not used it till now. I have only presented the data. I presume it is going to be pre-mixed. It is not still available pre-mixed in the form in this country, but it's going to take a long time for it to come pre-mixed. If you want to use it and you find the baby is going to go into early BPD and the ventilation requirements are very high, at the age of about 2 weeks, you can plan to give it. Porcine surfactant mixed with budesonide, probably you can give it, but I'm sorry about this. I will have to, because it's not something we are doing it routinely. We are not, as I said, it's still on the anvil, it's on the horizon. We have not started doing it.
So till then, sir, we follow the DART protocol for this?
I think you should follow the standard protocol. But then having said that, meta-analysis is available on the few trials which have been done on budesonide along with surfactant. It's available. Cochrane meta-analysis says it is helpful. But the exact modality, how to do it, I'm sorry, even the methodology in the papers is not clearly mentioned. I have to check this out. I'm really sorry about this.
Thank you, sir. Thank you so much.
We have come to the end of the session. I would like to thank our speaker, beloved speaker, Dr. Sunil, Dr. KARTHIK Nagesh sir, who have shared their years of experience and their the gist of their so many years, so many deep practice. And I'm sure what we have recorded or captured today. It's going to be useful days for all of us and all the youngsters and the practicing neonatologists. I'd like to thank all the participants who have been consistently being part of this session, right? And I would like to thank all my NNF secretaries who have been us and working tirelessly to make this webinar a success. And I would like to thank all the office bearers and my NNF beloved members of Karnataka and the people who have been logging in and supporting from throughout the country. Thank you very much. We'll catch up again. Thank you, Dr. Karthik sir, Dr. Sunil
Thank
sir.
you.
It was
I
a
must
wonderful
express
session from
my heartfelt thanks. Thank you so much. Carry on with the good, wonderful work you're doing. Thank you so much. And Sidhu, you've been a nice chairperson. Happy
Thank
to
you,
say
sir.
that you are my student.
Yeah, definitely, sir. You are my mentor, sir. You guys say that. That is what I said to Prashant, the same thing, that I would like to do the session today. And thank you, Prashant, for giving me to kindly moderate my mentor, Dr. Karthik Nagesh, sir.
Thank you. God bless you.
Sir, this talk will go long, sir. You have covered most of the topics. I think next speakers who are going to come in respiratory chapter will have a tough time because you have covered most of it, sir. Thanks a lot,
Thank
sir.
you. Thank you. God bless you.
Thank you, sir. Thanks a lot, sir. Thanks, Prashant, for having me.
Thank you.
Thanks a lot.
Bye. I'll catch up day after tomorrow. Bye.
Definitely.